I'd like to thank our moderators and the program committee at SAGES for the opportunity to review the data on complete mesocolic excision and D3 dissection versus conventional colectomy. I'm sorry, unfortunately, due to program restrictions, I have to be doing this talk virtually. As has been alluded to in earlier talks, the revolution of TME leading to improved outcomes in rectal cancer, decreased local recurrence, and improved survival have been impressive, and has led many to wonder whether or not we could do the same for colon resections, and whether or not extending nodal dissection could actually improve long-term outcomes. Our previous speakers have already reviewed the anatomy and some of the rationale behind complete mesocolic excision and D3 dissection, and Drs. Kessler and Ashburn will discuss some of the complexity of the technique behind the procedure. So today, I'm going to review the current data that's available in the field. Over the past decade, there has been a number of publications showing that there are currently around 30 plus series of retrospective cohorts or prospective series looking at the outcomes of conventional versus CME or D3 dissection. There are a few meta-analyses, one most published recently that I'm going to go through, and some ongoing and upcoming randomized controlled trials. The most recent meta-analysis was published in the Annals of Surgical Oncology this past March, and focus is primarily on perioperative outcomes, although it does look at some oncologic outcomes as well. Most of the data it mentions here, as you can see in the large table at the right, is retrospective with some prospective cohort studies going on as well, but only a single randomized controlled trial from the Russian group. And that particular trial had a total of 99 patients. Of the 30 studies that were included, a total of 21,695 patients were included in the comparisons, with 11,625 of those getting complete mesocolic or D3 dissection, and 10,070 getting standard or conventional laparoscopic right hemicolectomies. Not surprisingly, although the timelines are not very different, there are longer OR times with CME and D3 dissection. However, across the board, studies have failed to show a difference in leak rates, no significant difference in length of stay, morbidity, or mortality. You can see the box plots at the right, which really show that, again, these studies are generally small cohort or retrospective studies, and even in the pooled analysis, they've been unable to show any differences. When looking at oncologic outcomes in the meta-analysis, not surprisingly, as is the goal for this dissection, is that there is an increase in lymph node harvest. This increase in lymph node harvest is shown in most of the studies and across the board in the larger studies. There is also a notice of an increase in disease-free survival in the CME or D3 group. However, when looking out further at 5 years disease-free survival, if you'll see in the bottom box plot here, there is really no difference in the 5-year disease-free survival. Continuing with the oncologic outcomes, if you look at 3-year cancer-specific survival, looking at the studies that qualify, it does show an improvement in cancer-specific survival at 3 years. But again, as we look further out in 5 years, there's less data supporting cancer-specific survival. Most recently, out of a group out of China, a randomized controlled trial was published. This is the RELARC study, and this is a phase 3 superiority trial from 17 hospitals in China with a primary endpoint of 3-year disease-free survival. This study is still ongoing, and as a result, they have only published their short-term results. The primary Endpoint, as mentioned, was disease-free survival. Secondary outcomes they looked at were intraoperative and postoperative outcomes. This trial enrolled from January 2016 to December 2019 and included over 1,000 patients. 995 were included in their final intention to treat analysis. Results from this study show no difference in surgical complications, 20 versus 22% in the complete mesocolic versus the conventional group, and their study had no deaths in either group. Among surgical differences, the only thing they saw was that vascular injury was slightly more common in the complete mesocolic excision group, listed at 3% versus 1%. And the lymph node harvest, not surprisingly, was higher in the CME group, although if you'll note the lymph node harvest here, even in the conventional group, the lymph node number is high at 23. About 3% of patients had metastases in the central lymph nodes, so only 3% of their patients showed additional theoretical benefit from this, and no patients had metastases only in the central nodes and not in the more distal nodes. If you see the table on right, you get a sense of the cohort, which appears to be relatively equally matched. Again, looking at the operative results, the duration of OR time is slightly longer for the CME group, although only about 13 minutes. Vascular injury, as mentioned, was the only other real operative change. So the data are still out there. I think that there's a growing understanding that there is probably some oncologic benefit, although we don't know the long-term survival, overall survival improvement. We do know that CME and D3 are technically challenging, and as mentioned, Dr. Kessler is going to share with us some of his techniques for doing that. We have very little randomized controlled data, and the randomized data that we do have, the 3 trials that are either ongoing or recently completed accrual are on the right, and we are still waiting the long-term data. We do know that highly specialized experts have good results, and I think that's why everyone's here to discuss this, because we see that with properly skilled trained surgeons, that CME or D3 dissection probably does have benefits to improve survival. However, as we all know, there's an unclear impact on the general population because the majority of individuals doing colectomies remain general practitioners and not specialists. But I think our goals here at this conference and in the future should be to work on improving technique and skills so that more surgeons are able to perform CME and D3 dissections. Thanks so much for the opportunity, and I look forward to the panel later today.